want to thank John and Sally for the opportunity to speak. As Sally said, I'm a pediatric pulmonologist and have been involved in neuromuscular care for about 25 years, and have had a lot of opportunities to sort of evolve my thoughts and my care in neuromuscular disease, and was really excited to be able to come and talk about some of my thoughts and some of the pulmonary thoughts around bulbar dysfunction, and then some of the potential impacts. So the little slide up there says disclosures. There's nothing pertinent to this presentation. So I'd like to break this into 4 distinct parts. The first will be talking about why bulbar dysfunction, bulbar function is important to a pulmonologist, and then talk about the impact of inadequate bulbar function, and then some options for supporting bulbar dysfunction, and then related to that, some management principles and challenges. So the importance of bulbar dysfunction to me as a pulmonologist is that the posterior pharynx and all of the swallowing function is effectively traffic control. And we're all familiar with the challenge of feeding a tachypnic baby, and those challenges don't change as you get older. And so I'll be followed by an ENT physician who will go into some of the upper airway stuff in more detail, but just to point out the fact that on the image on the left, the patient's breathing, and then the uvula is downward, the epiglottis is up so that air can go into the trachea. In the middle slide, it indicates what happens when you're swallowing a bolus of food, where the uvula elevates and then the epiglottis closes over the trachea so that you don't aspirate material, and then you have the bolus of food safely going into the esophagus. And then in the third image, things have gotten back to the first point, where you have an open airway with a lower uvula, a raised epiglottis, and you can breathe effectively. And so this requires coordination, and that requires central nervous system input, which is why we sometimes see patients with static encephalopathy having significant bulbar dysfunction and aspiration risk, different than muscle dysfunction that we might see in SMA or other neuromuscular, other hypotonic conditions. So there are a number of different parts that I see as very important in secretion control. The first is reducing the risk of aspiration, and that's processing a combination of oral and nasal secretions and moving them safely into the esophagus and bypassing the trachea. The other thing is, once you have material around the trachea, is reducing the risk of aspiration. So being able to recognize something that's in the vallecula around the posterior pharynx, and then when that happens, closing the vocal cords. And then the next part that we'll spend the second part of the presentation talking about is, once you've aspirated or once you have material in the airway, how do we get it out? So supraglottis and glottis are obviously where much of this happens. And so we break things down into sort of volumes of aspiration. And microaspiration, as the name would imply, is small volume aspiration. Could be on the milliliter level, but it's happening repeated multiple times, causing chronic inflammation and sometimes interstitial lung disease. And then macro aspiration is larger volumes that can occur in a single episode or a number of small episodes, which can cause acute infection, inflammation, and sometimes lower respiratory tract obstruction. Subglottic, the subglottic action is involved in clearing what's gone beyond the vocal cords, removing aspirated or infectious material, and requires both recognition and then having an effective cough, which we'll talk about in a few more slides. So for microaspiration, this is something that requires a fair bit of attention and at least thinking through what might be going on. And there's no real good test to demonstrate microaspiration. One of the questions when you do have microaspiration is what is it? Is it acidic? Which acidic aspiration, even in small volumes, can cause very significant airway changes, bronchoconstriction, and then airway scarring, whereas milk or water will be less impactful. And then if you're when we see patients that have recurrent respiratory illnesses and may not have normal function, one of the things we think about quite early is whether there may be a component of microaspiration causing both soiling and then inflammation of the airway. One of the things that can lead us to a diagnosis is doing radiographic imaging, and especially doing a CAT scan to localize where the defects are, and then seeing if it's a pattern that would fit in with an aspiration. And I'll show you an example in a couple more slides. The other thing is if we have somebody that has a persistent supplemental oxygen requirement, which would be potentially due to inflammation in the interstitium, we often see that due to microaspiration. Evaluations for microaspiration are first just asking the question. I mentioned radiographic imaging. Sometimes what we'll do if we have a patient that is fed enterally is bypass the nasogastric tube. We'll do this in the hospital, of course, and sometimes doing that and then focusing on a symptom to resolve, whether it's tachypnea or a supplemental oxygen requirement, can then yield a pretty convincing diagnosis. And then sometimes what we'll do, and it drives our gastroenterology colleagues crazy, is just doing an empiric trial for reflux, assuming that the patient may be refluxing and then having aspiration of acidic material. The GI colleagues, hopefully they know gastroenterologists here, but the conflict is that they would argue that if you're empirically suppressing acid, then you're putting the patient at risk of actually having pneumonia. Because one of the things that the stomach will do with its acidic environment is it will kill bacteria that you have in your upper airway that you swallow through secretions. And then if that's not happening and you're actually refluxing, then the concern is that that can put you at risk if you are aspirating of developing pneumonia. But I suppose it's kind of a pick your poison approach. So for macro aspiration, this is a bit more obvious. So if you've had an event of aspiration, you can certainly get acute airway inflammation. And then we usually associate this with some type of an infection, pneumonia or bronchitis. Sometimes you're able to localize this on a radiographic image. If it's early and it's a if it's a radiolucent material, then you may not actually see where the aspiration has occurred. One of the things that can determine the risk of this if you do aspirate is whether you can remove what you've aspirated. And so if you have somebody that has a weak cough, then the likelihood of them having a significant aspiration-induced lung injury or episode of infection is going to be highly related to whether they can remove what they've aspirated. And then also recognize when they need to cough, and that's something that we see in patients with static encephalopathy. And so testing for the effects of aspiration, obviously we'd start with a radiograph and then move on to doing a chest CT if we're struggling finding where the material may have been aspirated to. This is a series of images from a patient that we recently had on service. It was actually a normal newborn that had a suspected, was being worked up for interstitial lung disease. And then when we delved into the story further, found that she was born just post-term and actually had meconium, and we presume had meconium aspiration. And I bring this up because the aspiration pattern is posterior, and so the baby obviously lying on his or her back would have aspirated material in the dependent parts of the lungs. And so if you have somebody that's upright, there can be a different pattern. So over on the left, if you look at where airways are a more direct shot from the trachea downward, that's where you're going to see aspirated material. We typically see material more on the right than the left because the right main bronchus is a straighter shot off the trachea than the left. For patients that are Lying down over to the right, you can see there are different segments of the lower lobe and the upper lobe that can be affected for patients who are bedridden, and that's sort of what we saw in the CT scan that I showed the previous slide. So how do we support bulbar dysfunction? Ideally, we'd reduce the risk of aspiration, and there are a number of ways of doing that. We can work on decreasing productions of secretions, making them easier to clear. The alternate approach, which is really the focus of today and yesterday's discussions, is to improve swallowing, or at least to maintain it, and being able to have the patient handle a normal volume of secretions, and then more importantly, handling an increased volume of secretions. And if you have a patient that can handle normal secretions when they're well, but when they get sick, their swallowing function is overwhelmed, then you have a problem. One of the things that we do for our patients, of course, is to give them additional ways of clearing upper airway secretions, and we have suction for that. And then when when things don't work and you are getting aspiration, there are a number of different strategies that we'll talk about a little bit later on replacing the cough. And one of the things I try and get a sense of from a family is before going forward with doing pharmacotherapy is finding out how much of a burden is it on them to be able to use suctioning and other airway clearance to keep their child safe. And I don't particularly care if a patient is drooling or is having trouble handling their oral secretions as long as they're not going into their lungs. And so I'll have an honest discussion with the family and see how much of a burden is it to suction and keep your child safe, and how much of a concern is it to you if they're drooling and having secretions coming out of the mouth. And if they say, we just carry a bunch of bibs with us, it's fine. I can actually leave my child to go in and get a drink of water in the kitchen without any problems, then I'm okay with that. And so I think ultimately for me, I try and make it a quality of life issue. So in terms of decreasing production, we can do this to hopefully reduce secretion volume, and there are a number of strategies. We can do anticholinergics, which Connie had mentioned at the end of her presentation, including glycopyrrolate, sometimes atropine, and then scopolamine. The only problem with the scopolamine patches that we have in pediatrics is that it's a singular dose, and in spite of some efforts, well-intentioned from others, you can't actually cut the patch and cut the dose in half. It unfortunately doesn't stay in the patch and it spills out. There are also, I didn't mention it here, but you can do Botox injections in the salivary glands to reduce production, and then sort of the nuclear option is doing a sciolectomy and tying off the salivary gland duct that goes into the upper airway. Nasally, it's important to keep nasal secretions in mind. We can do adrenergic agonists like Afrin or oxymetolazine to decrease nasal secretion production. And then, kids that have, you can certainly have, consider allergies and antihistamines. And then anti-inflammatory nasal therapy is probably the treatment of choice for nasal allergic rhinitis. Next slide. Another thing to consider is the potential for gastroesophageal reflux. I think everybody here, it's safe to say, has had an episode of vomiting at some point in the past, and when that happens, you salivate. It's part of a reflex, and so if you can address the physical component of gastroesophageal reflux, in other words, not just doing antacid therapy, that can improve or reduce saliva production. There's also a reflex related to esophageal acid contact that can increase salivary production. And so acid treatment is important as part of an official plan. The other thing is trying to prevent oral stimulation, which for some children or many children can cause significant salivation and then upper airway secretion burden. So one of the questions I would ask, and I ask continuously, is this, at least with pharmacotherapy, a fool's errand? Because you're effectively trying to use medications to replace something that's not functioning perfectly. And I think if you If you set an appropriate goal, I think it can be usable, but if the goal, reasonable, but if the goal is to make things perfect, I would argue that that's probably a fool's errand, in fact. So what we try and do is use medications to make the patient manageable. And one of the things that is important is recognizing that the body adjusts based on what the needs are. And so if you're using pharmacotherapy to try and control secretions, you need to do the same approach. And so once you get the optimal effect, then it's important to maintain it both by when you have resolution of increased secretion burden, then to de-escalate, decrease therapy so that you don't have the side effect of having thick secretions. And then when you have an increase in secretions during a period of weakness or dysfunction or acute illness, you need to have a plan for escalation. And so the idea of having a single dose that's used consistently is just not practical. The other thing is to minimize side effects and manage them appropriately. Pharmacologically, anticholinergics, in addition to drying secretion, can cause urinary retention. And sometimes we have patients that have intolerable urinary retention side effects. And then obviously, if you're drying up secretions, the whole purpose of secretions is to maintain the mucosal integrity. If you overdo secretion drying, then you can have mucosal drying, and that can put you at risk of mucosal trauma. And then if you thicken secretions and they're adherent to the upper airway, then for somebody that's weak, that can make it even harder to clear. And then if you happen to get into that place, what we sometimes will do is have patients use nebulized normal saline or other hydrating agents to try and decrease saliva viscosity and make it easier to clear. So obviously we have plenty of other people in this room more qualified to talk about improving swallowing function, and so that still is something that I find very important. And one of the things that it was also mentioned earlier is that once you shift from doing oral feeding to an alternate approach, it's still important to maintain oromotor skills as much as possible. Because even if you're not swallowing for nutritive benefit, you need to swallow to clear the upper airway. And that's something that when we, with our neuromuscular patients, when we pivot from oral feeding to G-tube feeding, we try very hard to continue to focus on. So for removing secretions, we cough or suction. Those are the only two things that can remove secretions. And so I'd like to talk a little bit about coughing. And there are three distinct phases. Obviously, the one related to the bulbar function I've highlighted there. But you start with a deep breath in, which requires your diaphragm, inspiratory muscles. And then you pivot to a forceful exhalation. Then almost immediately after that, the glottis closes for about 1/4 of a second, and then pressure builds up in the lungs, and then the glottis opens, and then you have an expulsive flow of air up the respiratory tract carrying secretions. And so if you have weak inspiratory or expiratory muscles, I think we all know that makes it hard to cough, but if you also don't have normal glottic function, that also can impact your ability to cough effectively. And so absence of either of these three can impact airway clearance. So here's an example of that. So the first phase, breathing in over on the left, and then you breathe out, the glottis closes, you have an increase in pressure in the lungs, and then the glottis opens, and then you pull all the secretions, hopefully, that you have on your airways up and out of the respiratory tract. So what's a normal cough? There are somewhat objective measures. There's peak cough flow, which was mentioned earlier, which is, as the name would imply, the flow that you generate when you take a big deep breath and cough. 160 liters per second, was suggested by John Bach as an important threshold, and that was based on the success of extubating an adult neuromuscular patient who was intubated for an acute illness. There's another value, 270 liters per second, which is a value, if you're below when you're well, foreshadows a value below 160 when you're ill. So that's the screening that we use typically for patients who are getting peak cough flow values. One of the challenges is that it's not widely understood what a normal peak cough flow should be in pediatrics, or even more importantly, in young patients. And so I think having an alternate approach of some more subjective question of how do you do when how does your child do when he or she is sick? And I typically, screen patients if they're able to get through an acute illness reasonably well within a week. I consider that pretty normal. But if that's getting up above 14 days, then I get concerned about cough quality, and then we'll talk about supporting it in some way. So there are a number of ways of supporting cough. The first three are what we'll focus on. You can make the patient or help the patient breathe in more deeply. You can help them breathe out more forcefully, or you can do both together. And then there's some adjunctive measures that we can add on also. So for doing inspiratory assistance, you can apply an inspiratory pressure. And this device here is an intermittent positive pressure breath device. This is called the Alpha 200, which is widely used in France and in some other European countries. And the idea here is that you're taking a deep breath in. The deeper you breathe in, the more air obviously goes into your lungs. And then with that, you have outward traction on airways, allowing airways that might be plugged with mucus to open to get air behind them. And then when you shift to exhalation, you have air behind secretions that can be used to mobilize secretions. So again, this is just helping the patient breathe in and does nothing to augment exhalation, in which case you're relying on the patient's passive recoil and whatever expiratory muscle function they have. You can do this with nebulization, which is nice because that can help to humidify secretions and make them a little easier to clear. So you can also do this non-mechanically, doing breath stacking with an oral nasal mask, and I'll show you an example of that in a moment. That's effectively using a ambu bag, resuscitation bag, to give a patient a number of tidal volume or above tidal volume breaths until their lungs are full, and then you remove the mask, and then the patient will breathe out as forcefully as they can. There's another way of doing this called glossopharyngeal breathing, which is using the pharyngeal muscles to actually augment inhalation. It's doable, but it requires a special therapist and a lot of patience. And I've not really had much experience with this, but this is certainly listed in the literature as one other alternative. So over on the left is a breath stacking device. It's just a bunch of cheap equipment that you can get from a typical respiratory stockroom. The right side of that has the red arrow, that's a one-way valve allowing the patient to breathe in. There's a Y connector there that goes to the patient with a padded mask, and then over on the left is an exhalation valve that's set to a relatively high pressure so that the patient could, if they really, really wanted to, breathe through it, but it allows patients to hold breath, air in their lungs. You can do this by putting an ambu bag on the insufflation part where the red arrow is to help the patient breathe in more deeply than they can on their own. The cough assist or mechanical inexsufflator device is in the middle. Parenthetically, this device by Hillrom Philips Respironics is now not being produced anymore, though there are a couple of other inexsufflation devices available. And you can use a mechanical inexsufflator to do just an inspiratory effort, just an inspiratory breath. And obviously you can add on exsufflation if you want to. And then the IPPB device is over on the right. You can also support exhalation, and you can do this here. This is an image from Michel Toussaint, who's a wonderful Belgian physiatrist who does a lot with airway clearance and neuromuscular disease. The top two images are at rest. The ones on the left are using chest compression. The ones on the right are chest and abdominal compression. The lower two images show the patient's chest or chest and abdomen being compressed to help with exhalation. You can do this with breath stacking so that you don't have any device that requires energy or requires much cost, to be very honest. So this is a perfectly valid way of providing expiratory assistance. This is work from Michel Toussaint looking at the left column and then the middle column are, as you can see, muscular dystrophy and then spinal muscular atrophy, looking at unassisted peak cough flow and then augmented exsufflation and then, using a thoracic compression and then thoracic and abdominal compression. And you can see that there's both a clinically significant and statistically significant increase in peak cough flow just by doing exsufflation. Most of the time we'll do both inspiratory and expiratory assistance. And as I mentioned earlier, you can do it non-mechanically with breath stacking and then manually assisted cough. The more traditional approach is using mechanical inexsufflator. This is the cough assist, and what we typically do is set a cycle of an inspiratory pressure ranging from 15 if we're starting and getting a patient used to the mechanics of the device up to 50 centimeters of water. And you typically hold the pressure for 2 to 3 seconds total. It takes about a second to get up to the prescribed pressure. And so you're really holding for 1 to 2 seconds. And then you shift almost immediately after insufflation to exsufflation, which is effectively suctioning. And that's typically done at about the same pressure. The typical treatment is 5 sets of inspiratory and expiratory support, suctioning, and then doing that five times. But we commonly counsel families that there's no way to know how many cycles of insufflation you need to clear secretions. Just like when you start to cough, you don't know how many coughs you have to make to get the mucus up you're trying to get up. And so there's a bit of an art to it. So this is some data also from Michel Toussaint looking at peak cough flow with 3 different ways of assisting. You can, the unassisted value is over there to the left, and then the next box plot is a manually assisted cough, so exsufflation assistance. You can see an increase in the mean peak cough flow, but it's not statistically significant. The third one over is after breath stacking, so insufflation assistance, you see an increase, but still not statistically significant. But if you put them together, you do get a statistically significant increase in peak cough flow, demonstrating obviously that if you do both insufflation and exsufflation assistance, you can get a much better increase in peak cough flow. This is from Michelle Chatwin from the UK, and this is telling a pretty similar story. Unassisted peak cough flow is over on the left, and then there's exsufflation assistance by chest compression, and then using a non-invasive ventilator to take a deeper breath, and then exsufflation with using suctioning, and then the final column is doing insufflation and exsufflation together, and that gives you the only significant increase of any of the 4 treatments. So insufflation and exsufflation is what we recommend. So to supplement, we like to think of mucus mobilization as a way to supplement airway clearance. Airway clearance is only coughing or using one of the treatments that we just mentioned. There is something called intrapulmonary percussive ventilation, which is nebulization done under pressure with vibration, and that is felt to help to make mucus less viscous and easier to clear. In the CF world, cystic fibrosis, there's something called vest therapy, high-frequency chest wall oscillation, which makes the mucus less viscous and easier to clear. But again, neither of these gets mucus out. It makes it easier to get out. And so one of the things that sometimes happens is that because people like devices and feel that what works in CF must work in neuromuscular disease, we'll have a patient that has one of these devices, but then is expected to cough and clear what's been mobilized. And that typically doesn't work very well. Also, borrowing from cystic fibrosis, we can do mucus hydration, which makes the mucus less viscous, but it increases the volume. What you're doing effectively is applying saline, either normal saline, 3%, 7%, or if you really want to live on the edge, 10% saline that gets salt into the mucus, water follows, the mucus swells, increases in volume, and then is easier to clear. And then there are other things that also come from CF to make mucus less viscous by breaking it up. Pulmozyme or Dornase alpha breaks neutrophilic DNA, which is in high concentrations in purulent mucus. And so that's something that sometimes will be used. And then N-acetylcysteine or mucomyst breaks up disulfide bonds between mucin molecules. And so all of those pharmacotherapy agents can make mucus thinner, but it doesn't make it come out. You still need to follow up with some type of an airway clearance treatment. So this is IPV, and this is, as I said, nebulization done under pressure with vibration. And that vibration is felt to effectively do what you would do by taking a small rug and shaking it outside. It's making the airways vibrate and taking mucus that's adherent to the airways and bringing it off into the airway lumen. This is a home device. There's a different type of device that uses wall pressure that we use in the hospital. And then with vest therapy or high frequency chest wall oscillation, what happens is there's an inflatable jacket that vibrates by having oscillatory air pressure applied. That's transmitted to the airways. And then what happens is that the airways vibrate, just like with IPV, and mucus is sheared from the airways. That vibration of the mucus is felt to decrease mucus viscosity, and it's very helpful in clearing distal airways. And as I mentioned before, it requires an intact cough. For IPV or vest therapy, there's really no indication at all to use it in a typical patient with neuromuscular disease. This is for patients that have airway, distal airway abnormalities. And so I say that only because sometimes parents will say, well, you know, we want to try this additional line of therapy. And we sometimes have difficult conversations, and I point out, well, you already have a cough assist, and that's really all that's needed to do airway clearance. This additional therapy may be helpful in an acute setting, but not chronically. There's absolutely no reason for daily therapy with vest or IPV. So there are some additional pharmacologic agents we talked about earlier for decreasing upper airway secretions. And one of the things that I think is very important to finish up here is what is the goal? I think if you set a goal of perfection, it's going to be really hard to make it. I think making things manageable for the family and the patient, I think, is a much more appropriate approach. And that is supplementing what residual function the patient has, and in some cases, hopefully making that better. And then having a plan that's dynamic, that increases pharmacotherapy and suctioning when needed at the earliest stage of acute illness, and then de-escalation. And I think in neuromuscular disease patients, it's important to keep in mind if they can't cough, then they're not going to show you the first sign of them beginning to get sick. And so we all cough. We all get bothered if somebody next to us is coughing because we assume that means that they're getting sick or they are sick. And so it's important to keep that in mind in patients with neuromuscular disease. And I try and have our parents have a very, very, very sensitive, be very sensitive to even small changes in their child, and then implementing their airway clearance therapy right at the beginning of an illness. And if that works, then sometimes that can be the difference between being able to manage something at home or manage something in an ICU or in the hospital, which obviously we'd like to avoid. The other thing that I think is important is trying to maintain some level of stability at home, and then acutely managing or aggressively managing infection, and then also, if we can decrease secretion burden, optimizing speech. And again, I'm not the one to talk about that, but one of the first observations I can remember when we started Nusinersen is having patients. There are about a half dozen, we could estimate 2 patients that we had in our group that were frequently in the hospital when they got sick, and I felt like they each had 3 marbles in each cheek, and it was very hard to understand their speech. And after getting pharmacotherapy, getting nusinersen, the frequency of hospitalization improved, or it went away almost completely, and then I could actually understand them. And so that really got me to think about bulbar dysfunction and how important it is. So that's all I have to say. I'm going to do a little bit of a pitch. At CHOP, we're hosting a symposium on transition of care, which is, I think, a necessary thing, in part because of the success of the drugs that we have for SMA and some of the other neuromuscular conditions. If you have any interest at all, there's a virtual component. If you happen to be in Philadelphia, you're welcome to show up on campus. And this is in honor of a patient that we had in our practice, Mohammed Haider, whose parents, about 7 or 8 years ago, when he became an adult, were able to give him a very high quality adult life, living on his own in Center City with support. And so this is not meant to celebrate anything in particular that we've done, but to start a conversation. So if you'd like to participate, there's a QR code, or if that's not working for you, you can certainly come up and I'd be happy to give you the contact info. So thank you for your attention, and see if there are any questions.
I have two questions. One is, what do you think of the Heimlich versus chocolators? Are you familiar with it? You can buy these on Amazon, and they're like plungers. And do you think that they're as effective as the Heimlich? Because I tend to teach the Heimlich. What do you think?
I've not had experience with, I know what you're talking about, and
Yeah.
I've been asked the question. I haven't had any experience with it, and I don't feel that I don't want to dismiss it out of hand, but I typically am a little bit dubious of things that you can buy online that may not have gone through a sort of a proper vetting process.
Yeah, I can't find any studies on it, so it makes me nervous too. And my second question is, what do you think about over-the-counter medicines to thin secretions, like maybe guaifenesin? Do you feel like there's any efficacy to using guaifenesin?
No.
Okay, that's what I've heard before too.
I think that, I think there's been less and less support of using guaifenesin.
Thanks so much. Great talk.
Thank you.
We are often the multi-million-dollar question in our patients who we know are aspirating. We see it every single day, every single mouthful, is when is that going to become problematic for them? So we see people doing this every day for 2 years and they are clinically asymptomatic. Sometimes we talk in our practice about the benefit of prophylactic chest monitoring and imaging, and I'm just wondering what your view is on whether that is a useful tool to add in for those we know are aspirating to detect any subclinical changes.
I mean, if you are reasonably certain that the child is aspirating and just want to see, I think that's reasonable. There are, dose-limited or radiation-limited CT scans that can be used. An X-ray, can show you some, but looking at the interstitium is really what would tell you that you're having aspiration-induced lung injury. And it will tell you regionally where it might be. And so that would be my approach. I wouldn't do it serially. I'd only do it if you had some reason to suspect aspiration.
Thank you.
Great talk. To follow up on that question, some of the severe late treated patients with profound deficits that we're trying to see if we can rehabilitate swallowing in any way. Is there, I know there's not a magic number for volume, but say we're starting with just water trials, really, really small volumes, like arbitrarily, honestly, I start with, say, let's try 5 ml max per day, in small little sips. Is there a certain number that you feel like after this point we would be more concerned with, aspiration effects and things like that we should limit it? I always try to be conservative in starting that out, but it's tricky in moving forward with these people.
It's an excellent question. And we were talking some about this yesterday, one of the breaks, about the difference between what you recommend to a patient and parent and what actually gets done at home. And I think if you're restricting feeding, that's something, I know in my practice, we see parents acknowledging, okay, I still give, give a little bit of juice because he or she likes it. I don't have a good volume in mind. Some of it would also be how effectively, if there is aspiration, can it be cleared? So I would actually, if we were working together and you said, can we liberalize things a little bit? I would say absolutely, and then we'd follow the patient very, very closely and see if they're beginning to have, tachypnea, or they're beginning to require supplemental oxygen, or something that would indicate developing lung injury.
So slowly advancing based on
Yeah.
clinical symptoms.
Yeah, and then
or
having
absence.
a good back and forth conversation, and I think we all like to swallow and eat, and I hesitate, I always hesitate limiting that. But I think you bring up a good question, and one of the things that I think is also important is, trying to maintain some amount of swallowing even when you're not doing it for nutritional benefit.
Sure.
And your question is very, very well placed, because if we say, well, 10 milliliters is reasonable, if you get one of that into the airway and it's just, a thin liquid, that's okay. I don't know what that value is, but I think it's something that I think we should think more about.
And then, I know at some centers I've worked at, they say if you're going to be doing this in high-risk patients that you think are aspirating, maybe, to wait for the trial when it's outside of cold and flu season versus not, so that you can determine, is it actually swallowing induced or is it something else? That's kind of the tricky thing. And you're not overly alarmed. Is that in your practice, or do you,
Not really.
for me, that's half of the,
Yeah.
it's cold most of the time. So.
And if you want to set the patient up in every single way to do as well as possible, that would be a reasonable consideration. But I think the world of viral infections is completely different. And so finding that window of time that's safe, I think, is very difficult.
Beautiful. Thank you so much.
Sure.
Thank you.
Oh,
Is
okay.
there another?
I was just going to add that some of our patients that we know aspirate, we will often make sure that they've got really effective airway clearance management in place. So there are some of our parents that choose to feed their kids knowing that they have an ineffective swallow. And then we just make sure they follow up with some airway clearance, so cough assist and suction as required, to try and prevent a secondary infection as a result.
I think that's a very appropriate way to do things.
Following up on the comment about how much aspiration is too much. So one of the strategies I've used, and I'd be interested in feedback, is we know from adults that an adult saliva swallow is about 1 cc. So we don't have comparable data in children. So that's one strategy of a place to begin when you know that they're handling their secretions by whatever mechanism that's worked out. But the question that I have is with viral loads, like we know from a study done a long time ago that following RSV, even children who didn't have swallowing problems could aspirate and aspirate up to a month later. It does, and we used to be in the situation where children could stay in the hospital long enough to do some resolution,
Right.
so you wouldn't be asked to do swallowing studies. But now people are being asked to do studies when children are still evolving from viruses. How do we balance that?
I guess the question is, what question are you looking to answer?
Yeah.
If you want to get an idea of how the child does at baseline, then obviously you wouldn't want to do it during an acute illness. But there's some, valid argument for doing a sick or a not perfectly well study. I think based on how challenging it is to, get patients in for studies, you'd probably want to maximize the, clinical utility and limit it to when the patient's well. But I could see an argument for both.
Yeah, because we often get children who then don't do well during an instrumental assessment, and then the providers are stuck with, what do you do next?
Yeah.
Yeah.
And we have the
Thank
same
you.
challenges in doing sleep studies to determine how a patient's sleeping at night.
Thank you.
Sure.
Thank you, Dr. Meyer.
All right. Have I worn out my welcome?
Thank you.